So good evening, everyone. Thanks very much for coming and for staying still there. Just for a really exciting session that we have ahead. So I would like to thank the organizers, especially Delvis, Charo, and Luis, for this great initiative, and especially Delvis for hosting us in his house, right? And I think we are really enjoying the climate and the food and the scenery. So for this next session, we have a great panel of experts, and we are going to be trying to address whether we can actually improve the outcomes of those patients with hard-to-treat tumors, such as small cell lung cancer and mesothelioma. So without further delay, I would like to introduce my co-chair, Dr. Manolo Cobo. He works at the hospital in Malaga, Spain, and I'm Ignacio Gilbazo from the Institute of Oncology in Valencia, Spain too.
Okay, we will start the section. Stephen Liu is known for everyone. He is perhaps one of the most expert in small cell lung cancer in the world, absolutely. He's a friend too. And he works in Lombardi Cancer Center, Georgetown University in Washington. And he is going to present how to improve the survival, the future, in metastatic small cell lung cancer.
Thank you. Well, thank you for that introduction, the opportunity to be here and talk about frontline treatment for small cell lung cancer. These are my disclosures. So one question we always ask ourselves, why has progress been so slow in small cell lung cancer? We had a whole day where we're seeing dramatic advances. We have more tomorrow. And yet in small cell lung cancer, you can count the major advances on one hand. Why is it so slow? What's different about this disease? Well, one is its pace. Rapid growth and spread puts us in a tough situation. One, patients are often symptomatic. They're in distress, and that limits progress in a few ways. One is patients need to be treated very quickly, so it can often be difficult to refer them to clinical trials or academic centers. But two, in terms of study design, they have to be pragmatic. And if I design a study where you need to send me a core biopsy, I'm going to do DNA and RNA-seq, proteomics, find out a subset, randomize, stratify, send that back to you, you'll laugh at me because those trials can't be done. Patients can't wait that long. We need to move quickly. And that really limits the types of studies that we can do. And because this is a smoking-associated cancer, patients have smoking-associated comorbidities. They're often fairly ill. They have lower reserve. And these are patients that often have a lot of poor prognostic factors to begin with. We learn a lot about non-small cell lung cancer and made a lot of the progress we had from the tissue studies that are very challenging in small cell. This is a central tumor, diagnosis often fine needle aspirate, where we lose a lot of the morphology, and the tumor banks that we use from resected small cell are likely reflecting a completely different tumor, maybe not representative in terms of biology from the cancers that we see in clinic today. In addition, and what kind of hurts us in small cell is the standard treatment works just well enough where a patient won't be referred for a trial because they can get that initial seemingly benefit from chemotherapy. And if we look at chemotherapy, our historic standard, we know response rates are high, north of 60%, 10% of patients with a complete response, but we also know they're very transient, with a median time to progression of about 4 months. That's from cycle 1, day 1. So patients generally progress shortly after or during chemotherapy, survival with chemotherapy hovering around that 8 to 9 month range. Patients come in sick, symptomatic, losing weight with pain, short of breath. We give them a pretty simple chemotherapy that is fairly well tolerated. Patients feel better very fast. And that immediate gratification, that feedback from an oncologist is just enough where they won't put someone on a trial and instead just give chemotherapy now, refer someone later at relapse, but at relapse it's really a different disease. It's part of the reason why our standard of care has been static for many decades before the integration of immunotherapy. And immunotherapy, make no mistake, this is a management that improves survival. The addition of immunotherapy to chemotherapy improves survival, hard stop. This is our standard of care. We have in Power 133, the addition of atezolizumab to chemotherapy, improving survival. Caspian, another phase 3 trial with the addition of durvalumab, improving survival. 2 phase 3 trials showing that the addition of a PD-L1 inhibitor offers a modest but significant improvement in survival, with a reassuring safety profile leading to its FDA and EMA approval and availability in over 100 countries around the world. Not only is that improvement in survival persistent, it is durable. And if we look at 3-year data from Caspian that Luis presented, we see that 3-year survival rate, about 18%. We see a true tail to this curve. That benefit lasts over time. And earlier this year, we presented long-term survival with atezolizumab, looking at Empower 133, and then the rollover Umbrella A study, a 5-year survival rate of about 12%. If we look in tabular form there on the right, 3 years, 16%, 4 years, 13%, 5 years, 12%. We have a persistent, consistent improvement in survival with immunotherapy. Now, I'm not delusional. I understand that this isn't the ALEX trial or the CROWN study that we're showing here. I understand that clearly we want more improvement than this, and it is modest, but it is significant, and I think everyone in this room has done more for less benefit. We have a 12% improvement in 5-year survival with standard treatment that'd be very close to 0. This is our standard of care. Immunotherapy really needs to be offered to everybody with advanced lung cancer, and we have multiple phase 3 trials showing the same thing. Now, some significant, some not, but all essentially showing the same trends. When we add a checkpoint inhibitor to chemotherapy, we improve survival. It's a modest improvement, but it is an improvement. This is now our standard of care. It offers the chance for long-term survival, something we couldn't offer before. Most patients don't get there. And the priority here is to develop more effective frontline strategies. And while we see a lot of activity in that salvage setting, and in our next talk, Haas is going to go over a lot of very promising second-line agents. When small cell relapses, it is a different cancer. It's a rapidly evolving biology, and it's part of the challenge with translating later-line therapies into frontline advances. In the second-line setting, far less responsive. It's a different population, and we have very high attrition rates in small cell lung cancer. If we look at a single institution, high quality, 100% of patients who receive chemotherapy, only half get any second-line treatment, and only 1 in 5 gets any third-line treatment. The impact in terms of patients' lives and in terms of advancing small cell really needs to be in that frontline setting. And it's our goal to really avoid progression. Progression for small cell is often devastating. Right? Where patients have little reserve, our greatest opportunity for impact has always been the frontline setting. It's really where we need to focus our efforts. But we don't have predictive biomarkers. And so what we know is that with standard chemoimmunotherapy, we have a 5-year survival of 12%. Maintenance immunotherapy, no improvement. Second-line immunotherapy, no improvement. So our only chance for long-term survival really is in that frontline setting. And there's a high bar to withhold a treatment that improves survival. And if I can't tell you, if the patient in front of you is in that 12%, I think you have no choice but to give that person immunotherapy. We need biomarkers to see who benefits, but maybe just as important, we need biomarkers to see who doesn't benefit, because in that population, you can explore alternate strategies. Without biomarkers, if I'm forced to give chemoimmunotherapy, I'm adding a 4th drug to this regimen. And that's a suboptimal strategy because it adds cost, it adds toxicity, and in some cases, you may be adding something that's antagonistic to the initial therapy. So what do we add to chemoimmunotherapy? Right, platinum, etoposide, we're going to keep a PD-1 or PD-L1 inhibitor. What do we add to this? I don't know. What do you got? All right, how about a CTLA-4? A lot of people swear by it. All right, if we look at Checkmate 032, which is largely Luis's patients, if you look at the 2-year survival rate of 26%, these are phenomenal. And some of these are 9th-line therapy, right? But this was not randomized. And Checkmate 032 had a randomized portion that we don't talk about quite as much because it's totally negative. Can't really tell from the graph, but trust me, no difference. If we look on the right here, response rate goes up with IPI. You double the response rate, you triple the toxicity rate, and no difference in median survival or in landmark survival. Caspian had an arm. We know that the addition of durva to chemotherapy improved survival. The addition of durva-tremi to chemotherapy did not improve survival over chemo. So towards the end, it kind of catches up to durva, suggesting that tremi is only being detrimental here. Now, it can't be CTLA-4. What about TIGIT? I love you, Delvis, but unfortunately, there's rationale for this, by the way. You have to trust me on that, but a very negative trial, the addition of TIGIT, not improving survival here. VEGF, very interesting data. We saw at World Lung from Ying Cheng, showing that benmelstobart, one of the more fun checkpoint inhibitors to say, plus anlotinib, improve survival, but this control arm is chemotherapy with placebo, not chemo IO. We have some it's uncertain the contribution of benefits. And the third arm in the study was with anlotinib, not with benmelstobart. So we don't really know if this is representative, but certainly intriguing, although at the same time, the CELEBRATE trial from our colleagues in Italy really didn't show a lot of promising signal with the addition of bevacizumab to carbotopatezo. So I think the jury is still out on the angiogenesis for small cell. If we can't improve maintenance, first-line therapy, maintenance is very appealing. And this IMforte study, I think, is a very promising one where instead of atezolizumab maintenance alone, you're adding lurbinectedin in. And the hope here is that lurbinectedin is more than just a cytotoxic, that its impact on the microenvironment and its relationship with tumor-associated macrophages will help convert more responders into long-term responders. We eagerly await the results from the IMforte trial. But in the meantime, what are we doing here? What are we adding to our backbone? There are a lot of promising drugs that Haas will go over. Antibody-drug conjugates targeting B7-H3 or DLL3, bispecific antibodies, bispecific T-cell engagers, trispecific T-cell engagers, radiation, radiopharmaceuticals, small molecules. A lot of these are promised. Will any of these lead to an improvement in frontline strategies? And a lot of these trials are already written, about to begin. Well, what we really need to find out is, are any of these synergistic? And true synergy in these combinations, as we know, is rare. But are they additive? Or are they potentially antagonistic, as we're seeing with some other molecules? Because in that case, it really is an alternate strategy. There are practical considerations to these, especially with T-cell engagers. Are these available and appropriate for all patients? Are these safe to administer? How do we select our patients? Our typical strategy when we try to advance small cell lung cancer is to take a drug that works well in the fourth, fifth line, move it up to second line, and eventually move it up to first-line therapy. We've got a lot of experience, another way to say it, long track record of failure with this approach, where it just hasn't worked. Right? And the challenges here are that consistently, response rate is not a good surrogate for survival. And this is also not a representative trial population. These single-arm studies are very difficult to interpret, and I think it's time that we move on from them. This is cubic pyrite. Cubic pyrite is fool's gold, which looks like it has value, but it does not. And that's really how we have to look at something like response rate, where a signal of activity is really leading us down the wrong path. We need to resist the allure of response rate and really look to durability, rationale, and survival as the meaningful endpoints here. But ultimately, there's no way around the need for biomarkers. And these empiric all-comer strategies, while they're appealing from a commercial standpoint, these will only lead to incremental change. If we treat everyone to benefit a small benefit, while there's value in that approach, it's not going to get us very far. The type of transformational change we want can only come with patient selection, and lack of biomarkers here has really limited progress in small cell lung cancer. We've all seen this curve. These are transcriptional subsets based on RNA sequencing data led by Charlie Rudin and others. And this clearly defines subsets of small cell lung cancer with a different biology. Right? And we know that the inflamed subgroup, which represents about 1 in 5 patients, they definitely seem to get a greater benefit from atezolizumab. There is an overrepresentation of that subgroup in long-term survivors with atezolizumab. But if you look at the green, which are our long-term survivors, we actually do see long-term survivors across the board in all of these. And am I willing to withhold immunotherapy from anyone based on these subsets? I am not. These do identify different biologic subsets, or maybe more accurately, different states, because the challenge here and why these are not yet ready to use is heterogeneity, and I think the biggest challenge is plasticity. And if I've got a tumor that can move from one subset to another, that's a moving target, and we need to adapt our treatment appropriately. We haven't been able to do that. Part of the challenge and what's working against us is we see such a great response that we can't do on-treatment biopsies because the tumor often is too small. Now, it may finally be changing with these data published a few days ago, tracking circulating free DNA methylation using blood and work out at Lauren Byers' lab. This can allow for tracking and dynamic changes of that small cell subtype evolution. Still not yet ready to use, but this is potentially the missing piece, where we can finally start tracking what's happening with our treatment and identify early who is not going to be a long-term responder so we can pivot and adapt. So how do we improve frontline therapy? First, we have to make sure everyone is getting first-line chemoimmunotherapy until we know better. We have to refer to trials. The enrollment speed now is much better than it was in the past, but still a long way to go. These empiric strategies, we have to do them, but they're only going to lead to incremental change. What we need are biomarker strategies really to lead to more paradigm shifts, and these need to occur in parallel. Right? From the people in this room, we need a large-scale investment, global collaboration in biomarker development to induce transformative change. It's time we all work together to really understand what's happening here. And with that, I'm going to stop with that message, and I want to thank Delvis and everybody for the, lost the last slide, I want to thank Delvis and all the organizers for conducting such a wonderful meeting. All right, thanks, everybody.
Thank you very much, Stephen. So we'll keep all the questions for the debate afterwards. So our next speaker is Dr. Hossein Bourguet. He's not actually here, and we have a recorded presentation regarding second-line small cell lung cancer.
Recent version. And as you can see, unfortunately, we still don't have a lot of options for the treatment of patients with recurrent metastatic small cell lung cancer. Traditionally, we've divided this group of patients into chemotherapy sensitive versus chemotherapy resistant. And the NCCN guidelines uses a 6 months cutoff to define chemosensitivity versus resistant. Again, as you see on this slide, obviously we're encouraged to consider clinical trials for patients with a chemo-free interval of greater than 6 months, retreatment with platinum doublet chemo.
Es que han empezado en mitad. So,
It's one of his better talks.
and shorter.
Most recent version. And as you can see, unfortunately, we still don't have a lot of options for the treatment of patients with recurrent metastatic.
Vamos a la siguiente.
The early show was better.
All right, so I think we're not having that presentation ready. So I think we're going to go next because we're running out of time, and we have the next speaker.
Yes. We pass now from small cell lung cancer to mesothelioma with
For the
the
treatment of patients with recurrent metastatic small cell lung cancer. Traditionally, we've divided this group. The data that supports possibly the use of a platinum doublet chemotherapy again comes from a variety of sources, including this more recent paper from 2020, where patients with recurrent extensive stage small cell lung cancer who had evidence of disease relapse more than 90 days, not the 6 months, but 90 days from their initial treatment, were re-challenged with platinum doublet chemo versus topotecan. And as you can see here, the PFS was in favor of the combination. But then it looked like the overall survival was different between the two groups. And moreover, grade 3 and 4 adverse events, including neutropenia, thrombocytopenia, anemia, and febrile neutropenia were reported, which again is expected in this disease. Lurbinectedin has gained a lot of attention. Many of you are familiar with this compound. This is a drug that is thought to have a variety of potential activities, including an impact on the tumor microenvironment, such that we think that it might actually alter the immune microenvironment enough to make it a little bit more receptive to the immunotherapy. In a single-arm phase 2 study, lurbinectedin was shown to have a response rate of around 22% in patients with chemo-resistant disease and around 45% in patients with chemosensitive disease. The waterfall plots are obviously shown on the bottom right-hand corner. And this drug is considered to have good clinical activity in the patient population as described. As you notice on the slides, though, the number of patients in each categories, with about 45 patients in the chemo-resistant arm versus about 60 patients on the chemosensitive arm, were kind of small. And again, this is a single-arm phase 2 trial. There was no comparator, but because of the response rate, because of the progression-free survival and overall survival that was reported, the drug has been used in the U.S. In the refractory setting. And again, here you see the clear distinction between chemosensitive and chemoresistant disease. The yellow colored graph shows patients with chemosensitive, again defined as greater than 90 days from the last chemo, versus chemo-resistant, which is shown in the blue graph. And again, these numbers are pretty good. I mean, to be able to reach a median survival around 11.9 months for patients with chemo-sensitive disease is actually pretty impressive. Safety is, again, very consistent across multiple different studies. And is, again, consistent with the traditional cytotoxic chemotherapy in that it does cause myelosuppression, and the use of growth factor support is encouraged. And hematologic toxicities, I think, included neutropenia, anemia. The non-heme toxicities, as you see here, included fatigue, nausea. So again, in a sort of a second, third line setting, as you see on this table, we have a few options. As listed, topotecan is the one that we have had for quite some time. In some parts of the world, amrubicin is also available. And again, as we just discussed, based on this single arm phase 2 trial, lorbenectedin. At this year's ESMO, I should say last year's ESMO, we got introduced to this particular combination, lorbenectedin with pembrolizumab in a relapsed small cell lung cancer setting. This was a phase 1/2 study of the lupus trial. The key eligibility included patients with small cell post standard chemotherapy. And again, as you see, this is a phase 1/2 trial, single arm. That the phase 1 included about 13 patients. In the phase 2 setting, there were 29 patients included. And the response rates, I would say, were very promising and interesting. Partial response of about 36% was seen in patients with a platinum-free interval of less than 90 days. And for a platinum-free interval of greater than 90 days, that response rate was around 46%. Again, fairly impressive numbers, but the number of patients involved were rather small. Progression-free survival was reported for the overall patient population to be at around 5 months. And again, chemosensitive and resistant is shown on the graph clearly, again, distinguishing between the two we see in the clinic. Safety analysis was consistent with what we had seen with lurbinectedin previously. There were no events. We also have had the option of looking at the treatment with T-cell engagers. So bispecific T-cell engagers have become available in the clinical trials. Tarlatamab is the one that has had the most amount of clinical data, one of the earliest ones to enter clinical practice. And there's been multiple presentations of the phase 1 study showing a response rate of around 23% across multiple doses of this drug. So this is again a bispecific T-cell engager. The tumor antigen that's targeted is DLL3, and the CD3 on the surface of T cells is the other antigen that's targeted with this drug, generating an immunologic relapse to sort of bring the T cells in close proximity to the tumor cell. This had a very extensive phase 1 study, and again, I think seeing response rate in a refractory patient population across multiple doses, around 23%, makes this drug interesting. What's more is that these responses appear to be very durable, and a progression-free survival of a median of 3.7 months and overall survival median of around 13 months for a particular drug. Here, we do have to worry about cytokine release syndrome as a potential adverse event. Majority of the events reported in this phase 1 study were actually of grade 1 and 2 nature. However, neurologic events were reported in up to about 50% of patients. 53% had cytokine release syndrome. Again, majority grades 1 and 2, but definitely there were some grade 3 or higher toxicity. So we do need to pay attention to these adverse if the drug does become available. In a randomized phase 2 trial, 2 different doses of this drug were compared to each other, the 10 milligram dose and the 100 milligram dose. And both doses were seen to be effective in terms of response rate, PFS, and overall survival. And this is the data from the article that was published on this. Moreover, the adverse events seem to be a little bit better with the 10 milligram dose, leading to the idea that perhaps this would be a more patients going forward. Another agent with similar mechanism of action is this BI 764532 drug. This is another novel DLL3 targeting T-cell engager. This also has gone through a rather extensive phase 1 evaluation. In this particular study, however, not only patients with small cell lung cancer, but also patients with other aggressive neuroendocrine tumors were allowed to participate. On a table that you see, there's data on about 132 patients, of which 54 actually had extrapulmonary neuroendocrine tumors. Again, cytokine release syndrome is seen with this drug, but 70% of patients, majority grades 1 and 2, and a few other adverse events such as pyrexia and dysgeusia has been reported. And again, I would say a response rate that makes this drug very interesting, as you see on the waterfall plot. The third drug is another DLL3 targeting T-cell engager. This particular drug by Harpoon has 3 different targeting modalities. One is CD3, one is DLL, and there's a third part that actually binds albumin to increase the half-life of the drug. The experience with this one has been a little bit more limited in that we have data on about 18 or so patients, again showing durable responses in a heavily pretreated patient population with a response rate of around 40%. and a safety that's very similar to what we have seen, except that at least based on this presentation that I have here, had not been any neurologic adverse events reported, although CRS was seen in about 20% of patients again. Then this field also has been impacted by the introduction of antibody-drug conjugate. Dr. Doherty presented the preliminary result from a phase 2 study of sacituzumab govitecan in a second-line treatment of patients with extensive stage small cell lung cancer, a single-arm study, very simple design, using standard dose of sacituzumab, reporting a response rate of around 37% with a median duration of about 6 months. The waterfall plot, again, as you see here, indicates that the drug can have activity. Again, unfortunately, there are really no biomarkers for this to help us figure out who would most likely benefit from this treatment versus others. And a safety profile that, again, makes the drug very interesting and worthy of further investigation. Obviously, in many ADCs, we see diarrhea and neutropenia. A majority of these are, thankfully, in the grade 1-2 range. But as you see on the slide here, up to 30% grade 3 or higher neutropenia was also reported. And then yet another antibody-drug conjugate, this one targeting B7H3, showing results. So I think overall, we're happy to see some activity in the clinical development arena for small cell lung cancer. Both the antibody-drug conjugate and bispecific T-cell engagers seem to have promising activity. Toxicity is an issue with both classes of drugs. The cytokine release syndrome and some of the neurologic events that we've seen with the T-cell engagers is definitely worthy of attention and requires appropriate identification and care of these patients. But again, luckily so far, most of these have been lower grade, and therefore I think early recognition of these adverse events is important. Biomarker has been an issue that's bogged us down a little bit in small cell lung cancer, and that challenge continues. But as it appears now, treatment options for this patient population remains a major area of unmet need. Thank you for your attention.
Okay, we pass now to another concept in mesothelioma with Dr. José Manuel Trigo, that is the medical director of the High Care Cancer Center that is in Marbella, in the Sun Coast. It's a paradise place. Of course, if you visit her, you will change the concept of the medical oncology.
So thank you very much. Thank you for the nice presentation. I would like to thank also the organizers for inviting me and also all of you for staying here at this time in the afternoon. I'm going to talk about the state of the art of immunotherapy in malignant pleural mesothelioma. As you know, malignant pleural mesothelioma is a rare disease. It's more frequent in men than in women. It's clearly related to asbestos exposure, and the latency between the exposure and the disease is very long, and usually are diagnosed as a very advanced disease where no possible curative treatment can be applied. This is the data for the Spanish lung cancer group. It includes a lot of mesothelioma patients, several stages, several different treatments, but the prognosis is very poor, and the median survival of this disease is only 13 months. There are several histologies, as you know. Epithelioid, which is the vast majority, can be very easily identified by immunohistochemistry. Sarcomatoid is the next one, and then a mixture of them, which is the biphasic. Usually we classify between epithelioid and non-epithelioid, which is a combination of sarcomatoid and biphasic. This classification is also prognosis. A sarcomatoid or biphasic patient goes very bad and epithelioid had the best survival. Also, this is important because the expression of PD-L1 in every histology is different. The histology that more PD-L1 expressed is sarcomatoid, and it could be important for the treatment of immunotherapy we are going to review. Also, there are some mutations in malignant pleural mesothelioma. The most frequent is EVAP1 that now is being investigated because there are targeted therapies against this mutation. We are not going to talk about this. The first line was based on this study that was published in the year 2003, and it's a randomized phase in malignant pleural mesothelioma who had received no systemic therapy. They were randomized to the standard of care, which is cisplatin plus pemetrexed versus cisplatin alone for 6 cycles. And this treatment was positive. It increased the overall survival. Median survival increased by more than 3 months. And another important thing is that response rate also improved. And the response rate for cis-PEM in malignant pleural mesothelioma is about 40%. And I would like you to remember this number, 40%, because it is going to appear several times during my presentation. So 40%. Another improvement was in the year 2016, where to this combination, bevacizumab was added. This study is positive. It increased the median overall survival. And every country has different policies. It is approved in some countries, not in other countries, but it improves survival, bevacizumab, when added to a standard cis-PEM. So as you can see, from the year 2003 until recently, 2020, we start now with to see the benefits of the immunotherapy. So what are the advances of immunotherapy in malignant pleural mesothelioma? The first study is a Checkmate 743. This is a randomized trial that included patients not previously treated with malignant pleural mesothelioma, and they were stratified by histology and also by sex, and it compared the combination of ipi/nivo for up to 2 years versus the standard of care, which is platinum plus pemetrexed for 6 cycles. The primary endpoint was overall survival. And this is the result. This is the 4-year updated result. You know that immunotherapy trials are updated every year. This is important to identify long-term survival, the same as in lung cancer. And it's a positive study. It increased the median overall survival by approximately 4 months in all the histologies. And we can see also some signs that there are long-term survival. However, the behavior of NiPo-EV is very different according to the histology. As you can see here, in epithelioid histology, the benefit is less. And see what is the benefit in non-epithelioid, which is about in between 9 and 10 months, with a very important hazard ratio. And also you can see that, for example, in the curves in the epithelioid, they cross at the beginning. They take very long time to separate. However, in the curve of non-epithelioid, it disappears from the beginning. And also in the long term, you can see that there are no long-term survival in the epithelioid histology. And for example, at 4 years in the non-epithelioid, the survival with nivo-ipi is 14% and only 1% with chemotherapy. This is the progression-free survival. The combination did not increase the progression-free survival. And also, according to the response, remember 40% was not increased by the immunotherapy combination with IO-IO. The duration of response was much higher with immunotherapy, and similarly to what we see in non-small cell lung cancer. Also, the toxicity was also higher with the immunotherapy IO-IO, ipi/nivo, and it's almost double the grade 3 related adverse event, and also the discontinuation of patients due to toxicity. So the improvement in survival is at the cost of improvement in toxicity. This is data from quality of life, improve the long-term quality of life, and also all the items of the quality of life with the combination of nivo-ipi. And this is the clinical guidelines. First one, they are different between the US and in Europe. This is a NCCN. They divide between epithelioid and non-epithelioid. In epithelioid, the preferred treatment, they include nivo-ipi as an option, but also the same category as chemotherapy or chemotherapy in combination with bevacizumab. But for non-epithelioid, the preferred treatment is nivo-ipi, and other treatment are the combination of chemotherapy plus minus bevacizumab. However, the ESMO guideline specify that the preferred treatment is nivo-ipi for all histologies, and they give a lot of importance to the performance status 0-1, and the combination of chemotherapy or chemo plus bevacizumab can be done as a non-preferred alternative and also at the progression of immunotherapy. In Spain, it's only reimbursed for non-epithelioid patients. And what about the first-line combination of IO plus chemotherapy? Because IO plus chemotherapy can combine the best chemotherapy treatment and also one of the best immunotherapy treatment. So there are several trials. There are two phase 2 that has been presented and published, and there are phase 3. One of them has been recently published. And in the phase 2, for example, in the DREAM study, it's a study done in Australia. They have a very good response rate for the combination of durva plus cisplatin pemetrexed. Overall response rate is 48%. And then encouraging median overall survival of 22 months. The PR is 0505. It's a study run in the US, and also it's the same combination. I have also a promising overall response rate of 56%. Remember, 40% only with chemotherapy, and also a median overall survival very high of 20.5 months. Then there are 3 phase 3 trials that are studying this durvalumab or bien atezolizumab or pemetrexed. And this last study is the IND 227 that was presented in the last ASCO meeting and has been recently published in The Lancet. This is a randomized patient, 440 patients that were randomized in an open label to receive platinum pemetrexed for 5 cycles or the same plus pembrolizumab, and then pembrolizumab maintenance for up to 2 years. So the study is positive. It increased the median overall survival. However, the clinical improvement of overall survival is modest. Okay, it's a little bit more than 1 month. But there is a different behavior according to the histology again. For example, this is for a non-epithelioid patient in which the improvement of the combination is more important, and also it seems that at 3 years there are long-term survivals. However, in epithelioid histology, we cannot see any benefit in survival. Also, if we look at the response rate, when we combine chemotherapy with pembrolizumab, we increase the response rate 38, 40%, with chemotherapy 62% with the combination of chemo plus pembrolizumab. This is the DREAMER study. It's a phase 3 study similar to the IND 227. But in that case, with durvalumab, a suggestive name, DREAMER, okay? It's been running in the US and in Australia, and it's recruiting the patient. And the other study is the top beat meso. It's a phase 3 study that the standard arm is chemotherapy plus bevacizumab, and the investigational arm is the same in combination with atezolizumab. The co-primary endpoint are PFS and overall survival. And this is a busy slide, but I promise that it's my most important slide, so don't sleep, please, because I would like to go in detail to this slide. This slide is not mine, but I'm going to explain in another way, okay? These are all the studies published that compare IO, it can be IO or chemotherapy IO versus chemotherapy, okay? And we only put the results of the immunotherapy arm. And we are going to compare what happened in epithelioid versus non-epithelioid mesothelioma. For example, here is the median overall survival of all the patients. They include epithelioid and non-epithelioid, and you can see that with either combination, the survival is very high. But if we divide it into epithelioid, for example, for epithelioid, it continues to be very high. But if we check at non-epithelioid histology, we see that chemo plus IO in non-epithelioid is very low. And see the combination of nivo-ipi is around 18 months, versus 9 months, 12 months with IO chemotherapy. More or less, something similar happened with the response rate. For example, the response rate, 40%, in this case with nivo-ipi, the same as with chemotherapy only. But it seems that the combination of immunotherapy with PD-L1 increased the response rate. But this is more important in non-squamous, in epithelioid histology. But in non-epithelioid, you can see that response rate of IO chemotherapy is very low, is much higher with IO-IO combination. So what that it means that perhaps in non-epithelioid histology, you cannot remove, or other way to say, the anti-CTLA-4 is very important in the sarcomatoid histology. For the chemotherapy IO combination, it can improve perhaps the response rate in epithelioid tumor. Okay, you can sleep now. So what's cell-based treatment second line and beyond we have? This is going to be every day less important as immunotherapy is moving to the first line. So these are phase 2 trials. More or less, they have a very good response rate between 7% to 29%. However, there are two important phase 3 trials. This is the PROMISE method by the top group, in which they compare after progression to chemotherapy, pembrolizumab versus the chemotherapy standard of choice, that it could be gemcitabine or evinorelbine, either IV or orally. The primary endpoint was progression-free survival, and this study was negative for progression-free survival and also for overall survival. However, pembrolizumab improved the response rate and not the duration of response. The other trial is the CONFIRM trial. This is pretreated patient, at least one prior line, and they randomized patient to nivolumab, and in this case, the standard arm was placebo, was not chemotherapy, gemcitabine or evinorelbine, and this trial was positive for PFS and also positive for overall survival. And the patient who most benefit, although are a small number, mainly for non-epithelioid, the major benefit was for patients with epithelioid histology. There are other targeted immunotherapies in clinical trials, immunotoxin, oncolytic viruses, dendritic cells. For example, in the World Congress of Lung Cancer, it was presented maintenance treatment was dendritic cell that was negative. And I think one of the most promising agents is the CAR T cells. CAR T cells are usually directed against mesothelin, and they are achieving very high response rate and very durable response rate with very pretreated patients. And these are my take-home message. The first one is that nivo-ipi is the standard of care in first-line pleural mesothelioma, irrespective of histology, but the most benefit is in patients with non-epithelioid histology. platinum pemetrexed plus minus beva is still a standard of care in the first line. What happened was the potential role of chemo-IO in the IO era. So we know that pembrolizumab platinum pemetrexed increased overall survival, but it's only for non-epithelioid. But as you have seen in the table, the benefit is mainly with IO. Also, we have seen high response rate in epithelioid histology, higher than chemotherapy alone, and perhaps it can have a role now in aggressive tumor, big tumor, where you need a better response than chemotherapy alone. But we need longer follow-up of this study, and also we are waiting for the result of the other randomized study of chemo versus chemo-IO. We need predictive markers, and perhaps I'm a dreamer, but I think we need direct comparison of IO versus chemo-IO in this cancer that has different histology with different behaviors. And that's all. Thank you very much.
Thank you very much, José Manuel. We're going to move ahead with the second part of the session. And yeah.
Entonces, lo hacemos así. Lo hace un poco más claro. Sí.
So I introduce Elisa González. She's also from Las Palmas. And Rolf Sangel, that needs no introduction, to join the panel for the discussion of these three presentations. Any questions from the floor?
You want to go first? Otherwise, yeah.
So maybe you can just start discussing.
Hello? Yeah? So I've got a very general question. Since the introduction of anti-PD-L1 in first line, in my clinical practice, I see the PFS that's described in the clinical trial, so maybe 2 months, 1.5 months. But I have observed that the patients that get to receive a second line have better responses and longer responses. Is this something that you have observed in your clinical practice too?
Not really. I mean, I think that hopefully it's a reflection that our drugs are getting better and that our supportive care is getting better. But I think that in non-small cell, we had a bunch of studies suggesting that after IO, docetaxel and taxanes performed a little better. I think in real world, larger studies, that signal wasn't necessarily there. And I don't know that that's necessarily true for small cell. I hope that it is. You know, the value of continuing immunotherapy in second line is one we talk about a lot. But I don't know that there's a huge rationale yet for it.
No, I meant that when you stop, so the patient progresses, the second line with whatever topotecan.
Yeah, not in my practice. I haven't really seen too much difference, but.
Okay.
Yes, Stephen. My question is, what are your thoughts on the limited disease small cell lung cancer, where we're still stuck with the old treatment? And a related question: yes, the patients are fitter. But do we have biological evidence that the tumor is similar or different than to the metastatic disease?
For limited stage? That's a great question.
Yes.
Yeah. So, I mean, we know that we have studies ongoing now looking at atezolizumab for limited stage small cell and durvalumab as well, and we'll see data from the Adriatic, from the NRG studies. The prediction here would be that the concurrent immuno with chemoradiation, that seems like a very similar design to Pacific 2. And you really worry if that's going to follow the same record where radiating the lymph nodes after immunotherapy might be detrimental. I hope not. But I think that it's an easy win for consolidation. And I expect those studies to be positive. And we should be hearing about them relatively soon. So I certainly hope so. Yeah. But if it's the same continuation of biology, I think is a really important question. And a lot of the limited stage are probably just understaged metastatic. But some that really are limited probably are programmed differently. And so they may respond differently. So we'll have to wait and see the data. I haven't heard any press releases yet, so maybe that's a good thing.
Yeah. And I have a question to Jose. Didn't say the name right? No. Yes. So Europe is divided in the mesothelioma field. with certain countries having the Ipi-Nivo restricted to non-epithelial. And then there's another division for some countries where you can give Ipi-Nivo second line and others that you can't or you can't. So I was wondering your thoughts that if pembrolizumab chemotherapy is going to be approved, which we don't know yet, will that change anything, what we do, what you do in Spain?
Well, at the moment, as I showed, it improved overall survival, but the clinical improvement is moderate, and I think I need longer follow-up, and I think I need to see the result of the other randomized trial of chemotherapy versus chemo-IO. I don't think that with this study is going to be approved.
So you don't think it's going to change the access of patients in Spain to immunotherapy?
Clearly not for non-epithelioid histology. I think epithelioid, the standard of care is Ipi-Nivo. And for epithelioid, we can discuss more deeply. Okay.
Yeah. Maybe I can ask the two of you a question as well. Consolidated thoracic radiation was not part of Empower 133 or Caspian. There's an ongoing study in the US looking at its role here. It's always been a practice much more common in Europe than the US. And so do you have any concerns about consolidative thoracic radiation, in light of Pacific 2? I know it's different doses, but is this something you would do today, and maybe both of you?
Well, it's clear from the discussion in Europe, there's some sites that do it without having data, and others who never done it. So it seems people seem to follow their habits. I don't know about you.
I guess when you have a disease that has such poor prognosis, it just makes sense to do something more, just as long as you feel it's not detrimental.
Yeah. However, there was this German study shown at the ESMO meeting where they stopped the trial early because of a high toxicity in the combined arm. But the high toxicity was a very strange type of toxicity, and we're thinking they stopped probably too early before they get the real result.
I agree with, it was surprising to me the result of this German study with consolidation radiation as well. So I got a question which is, in small cell lung cancer and mesothelioma, are quite similar in the fact that those tumors with more mesenchymal type, which tend to be more aggressive, are more responsive to immunotherapy. That is totally counterintuitive to me. Let's say, if you take small cell lung cancer patients, when they become resistant, they become transcriptomically more mesenchymal types. And they are more inflamed. Anyone got a clue?
Yes, my answer would be that non-epithelial are more resistant to chemotherapy, and that's why is the difference. And when you look at a curve for IO, it's really similar between the two. So that would be my explanation. Plus also the PD-L1 is more expressed in the non-epithelial. So
the only thing is that you look at the data, for example, in small cell, and immunotherapy is working first line, not later. When after chemotherapy, the tumors become more mesenchymal. So it's kind of...
yes, and Luis, perhaps for this reason, the anti-CTLA-4 are more important in this histology, the same as small cell lung cancer, where the combination of Ipi-Nivo is better than Nivo in the second line, not statistically significant, but the response rate is higher and the PFS a little bit, maybe. Who knows?
One question in the first line of small cell lung cancer, because we need to know what the strategy to improve the overall survival. What's your opinion about the disease? We have now the experience of urological tumors with enfortumab plus pembrolizumab. Do you think that is part of the future, generally in lung cancer and concretely in small cell lung cancer, the combination of ADCs plus immunotherapy? What is the role of the platinum, of carboplatinum? Because we have the sensation that in small cell lung cancer, adding more drugs that act in the immunological spectrum, no? more drugs with the TAMs, the Tregs, etc. The sensation is that we are not going to improve the survival because the mechanisms of resistance is inside the malignant cell. So perhaps we must employ strategies that are directly to the malignant cells, for example, the epigenetic therapy, or to try to improve the epigenetic therapy, adding to the immunotherapy, for example. What's your opinion about all of this?
I think I agree. I think that epigenetic approaches are interesting, but we have no way to target those either. We're turning things off and on sort of blindly. I think that the frontline use of ADCs there is interesting. The prediction, and I don't know if others have the same, but my prediction is that the second-line ADCs for small cell will probably mirror what we see in non-small cell, where you have a higher response rate, but I don't know that it'll improve overall survival over topotecan or lurbinectidine. In the frontline space, if it's going to make a difference, it'll be because of ADCC or disruption of the spatial architecture that allows more immune responses. I think it's the only hope that it improves outcomes. But part of the reason why we're seeing these differences between first line and second line, like Louis said, I think that when we give chemotherapy and we debulk that tumor, we disrupt the microenvironment in ways we don't totally understand, and some of those changes are probably detrimental to immune responses.
Yeah. But based on this little data we have with ADCs, TROP2, Z6, and B7H3, it looks like the likelihood that this way beat the topotecan is higher than the likelihood of beating docetaxel in non-small cell lung cancer.
We'll see. Topotecan is pretty tough for survival too, so we'll have to wait and see. Yeah.
So we are completely out of time.
Yeah. Okay. Thank you very much.
Thank you.
Thank you very much. And the next speaker, Ernest Nadat from ICO, from the Hospital Durán y Reynol, from Hospitalet de Llobregat, that is one of the most experts in brain metastasis in non-small and in small cell lung cancer. Thank you very much.
Thanks, Manolo and Nacho, for your kind introduction. I would like to thank the organizing committee and particularly Davis for this wonderful meeting. I am really enjoying today. I will talk about brain metastasis in non-small cell lung cancer. Do we need upfront radiation therapy? These are my conflicts of interest. And first, a few ideas. You know that brain metastases are a common issue in patients with non-small cell lung cancer, and they are associated with poor prognosis and also lower quality of life. And we need to recognize that the management during the last years have become more complex because we have now better local therapies, particularly SRS is becoming more used in the clinic, and our radiation oncologist colleagues are treating more and more lesions. Also, the surgeons have a lot of advance in their techniques. But one important idea is that during the last years, all the advances that we had in systemic therapies, particularly immunotherapy and targeted therapies, transformed the survival of our patients. And now also we started to use less and less whole brain radiation. That is making the management of those patients really complex. Other important idea is that when we have a patient in our clinic with brain metastasis, I like to think that I have a patient with two diseases, one in the brain and one out of the brain. And when we need to plan the best therapy for that patient, it's important to think in which is the therapeutic plan that could improve more the overall survival while preserving quality of life and the neurocognitive function, because, and that is not easy. If we start treating the patient with a local therapy, focusing on the brain, that is common in patients with symptomatic brain metastases, we are at risk that those patients, they could develop late toxicities like radionecrosis, or some patients could progress quickly out of the brain, and even they could die due to extracranial quick progression. If we focus in the systemic therapy, some patients, they could progress in the brain, and that is going to happen in many patients. And there is also a risk of losing some patients. Then I think one important idea is that those patients should be discussed in the multidisciplinary team, in a framework of a multidisciplinary team in which we can decide which is the best approach to patients. If we check what the clinical guidelines, European and American guidelines recommend, they are quite consistent. Patients with symptomatic brain metastases, they are candidates for local therapy, surgery, SRS, or whole brain radiation. In patients, and patients with asymptomatic, or the other concept that is a little more leaky, that is oligosymptomatic, that means patients that they could be controlled with anticonvulsivants or low-dose steroids. In this case, both guidelines recommend to discuss patients in the multidisciplinary tumor board. Particularly, we want to delay local radiotherapy. And they are quite consistent for, in one entity, that are patients that are harboring EGFR, ALK, and ROS alterations. For those patients, both guidelines, they recommend to use upfront TKI therapy, because we have amazing drugs now that they could control intracranial disease. But in the driver-negative setting, there is no consistent between both guidelines. The American guidelines are more conservative, while the European guidelines are more open-minded, and they already advocate for using upfront systemic immunotherapy in patients with asymptomatic brain metastases. Let's start with reviewing a little bit the efficacy of TKIs in patients with driver-positive disease. We know that patients with driver-positive non-small cell lung cancer, they are more likely to develop brain metastases. That is particularly true for patients with EGFR, ALK, and RET, but also RBB2 and MET skipping 14 alterations. Those patients, the likelihood of developing brain metastases is very high. And we can divide now theoretically the patients with driver-positive non-small cell lung cancer with brain metastases into two groups. The first group is defined by patients that harbor alterations that could be treated with high-penetrant drugs that can achieve very high overall response rate in the brain. And here you can see some results from different studies. The osimertinib in the FLOWER study, overall response rate 91%, lorlatinib in the CROWN study 82%, and entrectinib 80% in the pool analysis of several studies, sulpercatinib in the libretto 431 82%, and larotrectinib 88%. You can also see that the complete responses in the brain is amazingly high in some studies, and that is translating the high efficacy of those drugs. But I would like to highlight also the small numbers that you can see that have been reported within those studies, because these are the patients that they have evaluable brain metastases. We have also a second group of patients, that these are the patients that they have different alterations, that we are lucky that we have now active drugs. But for those patients that are KRAS G12C, MET skipping, RBB2 or BRAF, or we have a lack of data, for example, for BRAF or EGFR exon 20, that the data is very scarce. But or for the other drugs, we can see in this slide, we have compelling data, but the response rate is not so high. For example, adagrasib in untreated patients, the overall response rate is 42%. Only 3 patients achieve a complete response. Tepotinib in patients that are previously treated with brain radiotherapy, very high overall response rate, quite high, but no complete responses. And trastuzumab deruxtecan, we have seen some data at the past ESMO meeting, and we have some preliminary results that are promising, showing that ADCs could work also in the brain. If we focus in the studies that we have more mature data, that are FLAURA, CROWN, and Libretto studies, I would like to highlight that this very high overall response rate is also translated in very high PFS, intracranial PFS, as you can see in the upper curves, with a very high progression-free survival. But it's true that patients will progress at some point. At the bottom, you can see very interesting data also showing that those drugs are able to delay the appearance of new lesions in the brain. That is very important because these patients are very likely to be long-term survivors, and we want to delay the appearance of new lesions. What we can do to raise the bar of efficacy in this setting? We have different possibilities. Some of them, they have limited evidence, but I highlighted some of those here. for example, there are some small studies showing that TKI dose escalation, particularly for osimertinib, could reach some activity in the brain with an overall response rate of 50%. There are some studies that combine TKIs with local ablative therapy. For example, the Brighter study that combined brigatinib with radiation with oligometastatic ALK-positive non-small cell lung cancer with very high overall response rate. And we heard in the last ESMO a couple of studies that will be discussed tomorrow in which the TKI is combined with chemotherapy in the FLAURA2 study, osimertinib plus chemo, or amivantamab lazertinib in the Mariposa trial. And we have seen that for patients with CNS disease that are being treated with these intensified regimens, they can reach higher PFS than the control arm. And that is true for both groups, patients with and without brain metastases. And this is going to be probably discussed tomorrow further. Then I would like to divide to try to highlight the most important ideas of this section, that we can divide the patients in two groups. In one hand, we have some patients that they could be considered candidates to upfront systemic TKIs, for example, patients with common EGFR mutations or patients harboring fusions involving ALK, ROS1, RET, and NTRK, for which we have very high CNS efficacy. We have a separate group that are patients harboring MET alterations, RBB2, BRAF, EGFR exon 20 insertions, or KRAS G12C, that we have already compelling data showing efficacy, but the efficacy is not so promising or so convincing. And in these patients, we should consider upfront radiation or discuss that in the multidisciplinary tumor board. But we can decide if the patient is asymptomatic to use the drugs, but we should follow the patients closely because they are at risk of failing in the brain. Then let's move to a different situation, different setting, that are patients that are driver negative, that are candidates for immunotherapy. And we know that the brain niche is particularly challenging. That we know that tumor metastases in the brain are less likely to have CD8 infiltration, lower PD-L1. There is the blood-brain barrier, and there is a particularly immunosuppressive tumor microenvironment in the brain that could hamper the efficacy of immunotherapy. And let's start with this busy slide. This is the most important slide, as Jose Manuel said before. Don't sleep, later you can sleep. But this try to summarize the most important studies. We can divide the evidence that we have for treating patients with driver-negative non-small cell lung cancer with immunotherapy in two groups of studies. The top group is focusing on post-hoc exploratory analysis from pivotal studies. And at the bottom, we can see some specific brain metastasis trials. And we can also observe that the bottom, the top studies, most patients have been previously treated and controlled. They should be enrolled in the studies with prior local therapy. They should be recovered, and they should be off steroids, or they should receive very low dose of steroids. That means that those patients there is a very high attrition, and they have been highly selected. While at the bottom, we can see that in these academic studies, we were focusing more on untreated brain metastases. We require measurable disease in the CNS, and we allow in some studies a slightly higher dose of steroids. And also we can divide the studies according to the approach, only monotherapy, single monotherapy, dual immunotherapy blockade with chemotherapy, or chemoimmunotherapy. Let's review shortly a little bit all these studies. The first group of studies are those that are focusing on high PD-L1 patients with previously treated brain metastases, and we have data coming from the pool analysis from several keynote studies showing that pembrolizumab is better than chemotherapy, and patients benefit in terms of overall survival. We have also data from Empower Lung 1 that showing the same results, that in patients with high PD-L1, cemiplimab improve overall survival compared to chemo. We have also data coming from two studies in which patients with brain metastases were enrolled, but I would like to remind that all patients were previously treated and controlled. And here you can see the overall survival from CheckMate 227 and CheckMate 9LA. In terms of, this is the subset of patients with brain metastases, and you can see that there is an interesting result that was already seen in the ITT population, that for patients in the CheckMate 227, the curves are together, but then they become separated. And you can see that there is a significant benefit in terms of overall survival when we give the combination of ipi/nivo plus minus chemotherapy versus chemotherapy alone for this specific subset of patients. But there is also a very interesting result that we can check at the bottom, that the hazard ratio for patients with brain metastasis is lower compared with the patients without brain metastasis within the study, and this is statistically significant. That is probably due because the survival of patients with brain metastasis is very low, and probably this could explain this higher benefit. If we focus on the CNS PFS, the PFS intracranial, we can see here that there is the same trend. The curves are together, and they become separated in CheckMate 9LA. To me, it makes sense to add some chemotherapy, and we don't have access to ipi/nivo alone in Europe. And you can see that, particularly CheckMate 9LA is still significant in terms of median PFS, CNS PFS, with a hazard ratio very low of 0.42. And also, both studies demonstrated that the arm with ipilimumab could influence in the appearance of new brain metastases. That could be that we can speculate that could be protecting patients from appearance of novel lesions. We have also data with chemoimmunotherapy, chemo-pembro. We have the pool analysis from Keynote 021, 189, and 407. And these patients are a mixture because some of the patients were previously treated, while some patients were untreated, but they were all asymptomatic and off steroids. And you can see here that chemoimmunotherapy in this pool analysis also improved the overall survival compared with chemotherapy for patients with brain metastasis. And again, we have the same observation that particularly for this subset of patients, the hazard ratio is lower, 0.48 compared with 0.63. And this benefit was independent of PD-L1 expression. Let's move to studies focusing on patients with brain metastases, academic studies. This is a study from the University of Yale, from Sarah Goldberg. This is a small study in a single center, 37 patients, all PD-L1. They were asymptomatic, off steroids, and they were untreated. And you can see here that pembrolizumab in this population of patients without previous treatment in the brain achieved a 30% overall response rate intracranially, with some complete responses and very few dissociated responses when we see the brain compared with the body. And this is translated into moderate or very modest median PFS, but the median overall survival was 9.9 months. We have also data coming from, this is not academic, but this is an interesting study because it was quite open-minded and it was enrolling patients with special populations. It's the CheckMate 817, published last year, and it's including patients with ECOG2 and brain metastases. Only 49 patients, but these patients were not previously treated in the brain with local therapy. And you can see a very promising overall survival of patients with treated with ipi/nivo, 42% at 2 years. That is a quite good benchmark, despite the numbers are small. And we have also conducted a study within the Spanish lung cancer group, the TESOBRAIN study. It was a small study, but at that time, we didn't have much data. And we decided to, we enrolled patients with asymptomatic or oligosymptomatic brain metastases that were treated with chemoimmunotherapy, carboplatin, pemetrexed, atezolizumab, followed by maintenance up to 2 years. And the study was completed, and it was already presented. And the intracranial overall response rate was 40%. And we have seen also some complete responses in 4 patients, and also very few dissociated responses in 15% of patients. I would like to highlight that patients were allowed to enroll in the study up to 4 milligrams of dexamethasone. That is quite unusual because we wanted to be quite inclusive. And the median response rate, the median duration of response in the brain was 14 months. That is quite significant. The median PFS in the brain and out of the brain was quite similar, but it was lower in the brain based on random evaluation. It was 6.9 months compared with 8.9 months out of the brain. And one important message is that patients, they will require brain radiation when they will progress, and 60% of the patients within the study receive brain radiation. Most of the patients have brain radiation, but 8 patients receive still SRS, and the median time to brain radiation was 11 months. what could be the next steps? There are several knowledge gaps that are important. Now, as we are treating more and more patients with SRS, we need to integrate SRS with chemoimmunotherapy or dual immunotherapy. And I would like to comment briefly this study from MD Anderson that is a phase 1 study that is investigating how we can combine and give concurrently ipi/nivo with brain radiation. There is a cohort with whole brain radiation, or another cohort with SRS, and it enrolled 13 patients. 10 were evaluable for DLT, and there was only 1 DLT. And that is now continuing to try to demonstrate that a combination could be safe. But we are concerned about other issues, that those patients that they receive SRS at the beginning and they are receiving immunotherapy for a long period of time, they could be at risk to develop radionecrosis. And this is something that in melanoma is quite clear. In lung cancer, we have less data, but there are several retrospective studies showing that there are no differences. This is not randomized data. These are just comparing patients treated with SRS or patients treated with SRS and immunotherapy, and with the exception of one study, the other studies did not show differences in terms of radionecrosis. But it's something that we will face in our clinic, and that could be complicated to diagnose, and this is the other reason we need to come back to our tumor board to discuss with the neuroradiologists those cases. And we need randomized data, and we have one study that is being conducted by ETOP that is a randomized study including patients with lung cancer and melanoma, lung cancer driver positive and driver negative, and the study is investigating the role of upfront SRS with the standard of care systemic therapy or the standard of care systemic therapy and delaying the brain radiation. It's a nice study, but it could be challenging, the accrual, but I think it's an important question that should be responded. And to start finalizing, I think I would like to highlight, try to answer the question of the talk. Do we need upfront radiation? Yes, if we have a patient with symptomatic brain metastasis, we should consider local therapy. If possible, please avoid whole brain radiation. Talk to your radiation oncologist. We can treat more and more. We can treat patients with multiple lesions, and then that should be followed by systemic therapy based on the genomic profile of the tumor and other and a PD-L1. If the patient is not symptomatic and is harboring a treatable alteration and a genomic alteration, we can, as we commented, in some particular alterations, we can defer radiation and start TKIs. But in some other situations, we can consider to use local therapy because the data we have is not so compelling in the brain. If we have CNS progression, we need to discuss again if the patient is symptomatic or not. If it is symptomatic, we could consider to treat the patient with local therapy, but we could also, in case we have high penetrance, if the patient is not symptomatic and we have high penetrance drugs that could be like a new line of therapy, we could switch and change the therapy for those patients. And for patients that they don't have treatable genomic alterations, we can discuss if we can defer the local therapy or not. And we have several regimens that we can use. And for those patients, it's important that we can face pseudoprogression, particularly using immunotherapy alone. And for those cases, we can consider to use other criteria like IRANO, and we can consider also discuss these patients within the tumor board for deliver local therapy and avoid always, if possible, whole brain radiation. And just to conclude, I think that one of the most important ideas, I think there are residents in the room, one of the most important ideas, those patients should be discussed in a multidisciplinary tumor board, avoid whole brain radiation as much as possible, and we can use upfront SRS and surgery in some cases, it depends on the lesions. For symptomatic patients, it is recommended. For patients that are asymptomatic and they are driver negative, they can be treated also if they have lower, if they are candidates for drugs that they have lower CNS efficacy, and also it can be considered for patients that are asymptomatic with driver negative, in which we should discuss if we cannot, we can discuss within the team to use local therapy and then start immunotherapy. And that's all. Thank you for your attention.
Thank you very much, Ernest, for such an inspiring talk. And I would like to call next speaker. She's Claudia Proto from Istituto Nazionale dei Tumori in Milano, Italy, and she will be talking about thymic carcinoma. Welcome.
Thank you. Good afternoon or good evening, everybody. And thanks for this kind invitation. For me, it's a great pleasure to be here today. I'm going to talk about thymic carcinoma. And as the title of my presentation says, finally, something is changing, something is moving. These are my disclosures. Thymic malignancies are a very rare pathology, but they represent the most common cause of tumor of the anterior mediastinum. According to the WHO classification, that is an histopathological classification, we can distinguish thymomas from thymic carcinoma. That have different histologies, different histopathological characteristics. For all that which concern thymic carcinoma, the most common subtype is squamous cell carcinoma. And thymic carcinoma among the subtype is that with the lowest incidence, but it is also the subtype with the worst prognosis, with a 5-year overall survival of 30%. So I want to underline that the diagnosis of thymic malignancies is still challenging because of the rarity of disease and also of the intrinsic heterogeneity of these pathologies with the different subtypes. So it is very important the expertise of the pathologist, and it is always recommended a second pathological look. And as you can see from this cake, when we perform a second pathological look in a referral center, there is a high discordance among pathologists with a high rate of unconfirmed diagnosis. And it is important because we have these different subtypes with different sensitivity to the treatment. Another aspect that we have to underline is that thymic malignancies need a multidisciplinary evaluation with figures such as the medical oncologist, the surgeon, the radiation oncologist, but also the dedicated pathologist, and other figures that are required to better understand and follow the autoimmune disorder that frequently are associated with this disease. Talking about the staging system, we know that until recently the unique staging system was the Masaoka-Koga classification. But in 2017, with the 8th TNM edition for thoracic malignancies, a new classification was approved also for thymic malignancies. And here we have the most important changes. In particular, according to the impact on prognosis, in the 8th edition, we can see a larger number of patients classified as stage 1 that included the stage 1 and 2 of the Masaoka-Koga, and also patients with extension to mediastinal pleural. In the stage 2, we have the involvement of pericardium, and in stage 3, with the involvement of other thoracic structure, we have a better stratification in 3A and 3B according to their resectability or not. For the stage 4, we have a better hand stratification with the involvement of peritomic node in the stage 4A. And for distant both lymphatic and hematogenous metastasis, we have the stage 4B. But if the 8th edition is currently used, we have already a new proposal that is arriving in the next month with the 9th edition TNM. And here we have important changes that refers to the T component. In particular, the size become an important prognostic factor. And in the stage 1, we have a distinction of tumor in T1A for dimension less or equal to 5 centimeters, and T1B larger than 5 centimeters. The extension of the to the mediastinal pleural in this new proposal has been removed because it is an histopathological descriptor. And another change is relative to the involvement of lung and phrenic nerve, because this involvement has a prognosis that is more similar to that of the involvement of the pericardium, that is stage 2, than to that of the other T3 tumor. So there is a reclassification from T3 to T2. But no changes are proposed for the N and the M component, and the stage remain the same. Going to the treatment, we know that the mainstay for these tumors is surgery. And so when it is possible, we have always to perform surgery. But we have no particular changes in the early stage, where for the medical aspect, the adjuvant or neoadjuvant chemotherapy is the standard. Some changes are evident in the unresectable disease. We know that in the metastatic setting, chemotherapy, platinum-based chemotherapy, is still the standard as first-line treatment, with carboplatin and paclitaxel that is the preferred choice for thymic carcinoma. No standard second-line option exists. Here we have all the possible chemotherapy combination that we can use. After a progression to a first line with a platinum-based chemotherapy, a re-challenge with a platinum-based chemotherapy has to be considered. And then we have other combinations, such as capecitabine, gemcitabine, pemetrexed, that as second line have a response rate of ranging from 5 to 30% with median progression-free survival of 7 months. But what are the news to have more important results? First of all, I want to show you the result of the relevant trial that we presented at the last ESMO. Relevant is a phase 2 prospective trial, an effort of the Italian Time Network, in which 35 patients with thymic carcinoma, untreated thymic carcinoma, and with no major contraindication to antiangiogenic, were treated with a combination of an antiangiogenic, ramucirumab, plus carboplatin and paclitaxel, followed by a maintenance therapy with ramucirumab as monotherapy. And this study met its primary endpoint with an objective response rate of 80%, a disease control rate of 100%. Responses were important, with important tumor shrinkage, and they were durable, with median duration of 15.9 months. PFS was 18 months, median OS 43.8 months. The toxicity profile was quite manageable, with grade 3 or higher toxic events related to ramucirumab in 25% of cases. But if we look at the most common adverse event in more than 10% of patients, they were mainly related to chemotherapy, and there were of grade 1 and 2. We know that this is a single-arm study with a small number of patients, but these are the best results of ever in this setting. As regards second-line therapy, we know that a lot of target therapy have been evaluated in this setting, but with the lack of driving alteration, the most part of results were negative. We have positive results with the use of anti-angiogenics, such as sunitinib, with in thymic carcinoma 26% of response rate, lenvatinib with a 38% of response rate. And this is a phase 2 trial that really confirmed recently the activity of sunitinib at standard dosage in patients with thymic carcinoma progressed after at least one first line with platinum-based chemotherapy with objective response rate 21% and disease control rate 89%. In this study, there was also a cohort for B3 thymoma, but it was closed early for futility because sunitinib did not achieve any response. To confirm the activity of the anti-angiogenic, we have this Chinese phase 2 prospective trial that evaluated a new anti-angiogenic apatinib directed against VEGFR in the same population of pretreated thymic carcinoma and thymomas. And as you can see, the study confirmed the activity of the anti-angiogenics with objective response rate 40%, disease control rate 84%, and encouraging median progression-free survival and overall survival. But what about immunotherapy in thymic malignancies? We know that the risk of immune-related adverse event and of the worsening of pre-existing autoimmune disorder limited its use in the thymomas. But the result in the setting of the thymic carcinoma are promising with some activity, in particular for pembrolizumab, with 23% of response rate in pretreated patients. But results are controversial. Here we have also the recent result of the NIVO-THEME study. The NIVO-THEME study was a phase 2 prospective multicentric study that evaluated to distinct cut the activity of nivolumab as monotherapy or in combination with ipilimumab. These are the results for the cohort with the monotherapy. And the primary endpoint was the progression-free survival at free survival rate at 6 months. And as you can see, nivolumab achieved a 35% that showed some activity, but was not sufficient to declare the study positive. And so we can say that this study confirmed activity of the immunotherapy with promising also PFS and OS, but it is not positive. Moreover, we have some grade 3 and 4, 26% of toxicity. And it is important because in this patient, also if they are thymic carcinoma, we have to better control the toxicity profile of the drug. But to improve the activity of the single agent, in this study, based on the potential synergistic effect of the two drugs, for the first time it was evaluated a combination of an immune checkpoint inhibitor, avelumab, and an anti-angiogenic axitinib, always in the same population of pretreated thymic carcinoma and B3 thymomas. And as you can see from the waterfall plot, the response rate was 34% and disease control rate 91%. I want to underline that this was a population with a heavily pretreated population with a median of 2 lines of treatment, and the treatment was active also in patients that had previously received an anti-angiogenic. The toxicity profile showed also in this case some immune-related adverse events with polymyositis, myocarditis, and so we have to better understand the safety profile of this combination. And at the moment, another trial, the Pecati trial, is evaluating a similar combination with pembrolizumab plus lenvatinib in the same setting. So we are waiting for this result. To conclude, this is a retrospective analysis, real-life analysis in patients with advanced thymic carcinoma that were treated as first line with a combination of an immune checkpoint inhibitor and plus chemotherapy, platinum-based chemotherapy, versus platinum-based chemotherapy alone. And as you can see from the curves, the addition of the immune checkpoint inhibitor showed an improvement in median progression-free survival with another ratio of 0.46, with the limit of the retrospective analysis showing that this combination may be active also in thymic carcinoma. To conclude, what are the take-home messages? First of all, that for the thymic malignancies, it is necessary a multidisciplinary evaluation with a dedicated pathologist to better understand the disease and to better classify them and to better define the therapeutic strategy. The classification of this disease is improving with the next arrival of the 9th edition to better classify this disease and to define the therapy. The addition of ramucirumab to carboplatin and paclitaxel showed important results, but at the moment it is not available as first-line treatment. What we have are anti-angiogenic and immunotherapy treatment that are not the standard, but are available with some particular indication of label indication. The NCCN approved pembrolizumab. So when we have this drug, we have to consider that for the treatment of our patient. Of course, further studies are required, but it is difficult in these pathologies to perform large randomized trial. Thank you.
Okay. We claim from the floor to Martín Lázaro and Margarita Mayen, and to start the discussion.
So we just have a few more minutes for some questions, burning questions, I would say. Is there any question from the floor, or do you just want to start?
Okay, thank you very much to my friends to invite me to participate in this meeting, because we must have a good friends even in the hell. The hell by the color of the scenario. And I have a question for Ernest. Given that we are very concerned about the occurrence of cognitive disorders, do you think that to what extent can systemic treatment provoke cognitive disorders and influence the subsequent local treatments?
Systemic therapy. Yes. This is well studied, with particularly in breast cancer. We have also interesting results in small cell lung cancer patients that they could develop chemobrain, and in addition we use PCI. That is even a major issue. But it's true that we don't have a lot of data in the present analyzing the cognitive disorders related to systemic therapies. In the Tesobrain we analyze it's only 40 patients, but what we can see is that the quality of life and the cognitive function was preserved during the period and up to progression. No? But it's complicated. That requires expertise, and you need to take into account other factors, because these patients many times they require anticonvulsivants, or they could have also progression of disease, and that could affect also the way they're thinking, no, and work and how the brain is working.
Thank you. You want?
We have a question from the floor. Tomeu, please.
My question is to Ernest. If I understood well, you advise prioritize local therapy in case of KRAS G12C and BRAF mutation, but we have results, good results, at least in my opinion, in brain mets with adagrasib, and not specifically in lung cancer, but in melanoma with combination BRAF and MEK inhibitors. What is the reason
No, I was
for
quite
that?
conservative, respecting the guidelines on one hand, because the guidelines in this case, they say that at least we should discuss those patients. Obviously, there is the possibility, if they are asymptomatic, to initiate TKIs and observe the patients. That is perfectly good. But on the other hand, we don't have a lot of data, or the efficacy data we have is very limited. And it's true that adagrasib yields, it's published in JCO, 40% response, which is not bad. But it's true that, on the other hand, the duration of those responses were shorter in the brain. And then I think we need to be a little bit careful, because we are assuming, what I wanted to do is not extrapolating automatically what we learned from EGFR, ALK, ROS to other drivers, and to think a little bit more that we should be careful in this particular group of patients. But I am not advocating to treat all patients with SRS, but at least we should discuss that with our colleagues.
I have two questions for Dr. Proto. Thank you so much for your presentation. I would like you to explain us a little bit better how does the second look pathology team works, because it's a little disappointing, the results we have when they revise the biopsies. And also the second one is, given the excellent results of the relevant trial, which would be your first choice, chemotherapy plus immunotherapy or anti-angiogenics?
Okay. I start from the first question. Thymic malignancies are very rare, and we have also a great heterogeneity in the pathology. And we have some small difference among all the subtypes. So the data that I showed was a revision, a second look in a referral center compared to small centers that for the first time have a diagnosis. We have some important changes because sometimes we have an unconfirmed diagnosis, sometimes we have different tumors, and other times we have different subtype. And it is important to have a dedicated pathologist because it can impact on the choice of the treatment, because we know that the subtypes have different sensitivity to treatment, and so we have to make the best diagnosis. For the second question, I hope that in the future we will have both the combination with anti-angiogenics and both the combination with immune checkpoint inhibitors. I think that we have to select patients for one or for the other treatment. We know that thymic malignancies are difficult for the position in which they are, and so the use of anti-angiogenics is difficult sometimes. We have to exclude the patient with major contraindication to anti-angiogenics, with risk factors for anti-angiogenics. And I think that the same is for the immunotherapy. We have to exclude the patient with autoimmune disorders or other risk factors for the development of immune-related toxicity. So we have to evaluate, in my opinion, case by case.
Okay, thank you.
Sharon,
So
please.
this is for Ernest. Congrats, because I really enjoyed your talk. You have mentioned the fact of dissociative responses. It's not very frequent, but they may happen. Two questions. Any tumor or clinical characteristics that may to predict this fact? And how do you manage the situation in your practice?
Yeah, we still don't have a clear predictive marker for those patients. Now we are analyzing the brain MRI from the study to try to learn a little bit more. We suspect that lesions with more edema, maybe they are more challenging in general, but it's true that we need to analyze the data to respond to that question. Probably other biological features also should be taken into account. But it's true that at this moment it's difficult. And in the study, what we did is they had dissociated responses and they were progressing in the brain. It was allowed to treat the patients locally and continue with the systemic therapy if they were maintaining systemic response. We're quite inclusive in this regard. Obviously, if they were progressing out of the brain with response in the brain, we should switch the systemic therapy. But in case of brain progression, I think we should come back to the board and discuss those cases. And I think many hospitals are becoming more and more active in delivering SRS and avoiding whole brain radiotherapy.
Stephen, you first.
So if a CNS penetrant TKI is not an option, how do you manage leptomeningeal carcinomatosis?
We use, in case we don't have a high penetrant, okay, we used to combine the best systemic therapy we have, and in some cases we consider to use intrathecal chemotherapy in some patients. But because the data we have also with immunotherapy in those patients is very modest, there are some trials that are trying to apply also intrathecal immunotherapy. There are some academic studies at this moment, but it is a bit tricky. But we have a very good collaboration with a strong neuro-oncologist team. And we have a cohort of patients that have been treated, but in general, we have very poor options for those patients. What we can do, obviously, if they are ALK or EGFR, is to use the drugs or even to escalate in case of osimertinib, despite the data we have with the Pulmón study is limited. But for the other patients, it's very challenging, yeah.
But for those patients, you used to do also whole brain radiotherapy or not?
No, if they have leptomeningeal disease, we avoid whole brain radiotherapy because it's indeed for us a contraindication. They have very dismal prognosis, and some retrospective cohorts show that it's not very it's not an active option for those patients.
Okay, thank you very much. No, my question for Claudia. Thank you very much for your talk. Because usually when we are treating thymic carcinoma or thymic tumor, we are really concerned about the toxicity of immunotherapy, especially for that. Because at least for me, is one, first of all, to use anti-angiogenic in this central tumor so close to the great vessel is really a great concern. But also because, on the other hand, immunotherapy. How do you manage that? How is the grade of Bergstein with immunotherapy in those tumors?
We know that thymus, for its nature, is the cause of a higher rate of immune-related toxicity that are higher in the thymomas and lower in thymic carcinoma, but they are always present. And in all the study that I showed, there were a higher rate of immune-related toxicity, myocarditis, polymyositis. So I think that if immunotherapy is available in clinical, will be available in clinical practice, we have to follow patients with a close monitoring because the risk of an increase in grade 3 or higher adverse event is present, but less than in the subtypes of thymomas. And the same is for the toxicity of related to the anti-angiogenic, the embolic event, the bleeding. So in any case, a patient with major contraindication have to be excluded from this treatment. And then we have to follow them closely.
Yes. No question from Solange?
Yes. Okay. Yes. I have a question for Dr. Proto about if you think there is a role for adjuvant radiotherapy or chemotherapy in thymic carcinoma. Radiotherapy basically with R1 surgery.
Yes, yes. The chemotherapy for the adjuvant setting is used in the advanced stage. For radiotherapy, we have some controversial indication. Recently, we have a publication that says that the major advance from adjuvant radiotherapy is in advanced stage for thymic carcinoma because the early stage did not show an advantage for the addiction of postoperative radiotherapy. It is indicated always when we have an incomplete resection, but it is useful in particular for the advanced stage of thymic carcinoma if we have a complete resection.
So last question, Solange, please.
Thanks, going to be short. Is to continue on the question of Stephen to Ernest. The leptomeningeal carcinomatosis, because the more we treat this patient with GFR ALK, the more we see them on a daily basis. Chemo intrathecal. Remember the old books in oncology were giving some methotrexate, cytarabine, just improving somehow the symptoms, but not the survival. We have new data from Asia with pemetrexed. It's phase 1, published in JTO, but we are all ending up trying now to give it. What do you give as a drug? You are probably more experienced. What do you choose? Because usually you have only one line of intrathecal chemotherapy, right? Do you use pemetrexed?
We didn't use it because it was not accepted in our center, but we have used more topotecan. There are also some studies with topotecan showing that the toxicity is much lower than methotrexate. Methotrexate, one of the issues is that it can cause a very important leukoencephalopathy, and if the patient survives, the toxicity will appear. But pemetrexate data is very interesting, but also it's a study that has several caveats. But it's true that it's something that I commend the authors because it's very hard to conduct this kind of studies in patients that they are very sick, and it's not easy to enroll patients with carcinomatosis, leptomeningeal carcinomatosis. But it's true. I didn't comment on that. Thanks, Solange.
So thank you very much, all the speakers and also the discussants, because of a great job and a great discussion and terrific presentations. We have no more time.